Hey guys, here's your week 6 update. So this week we talked about adhesive capsulitis. For diagnosis, it can be either primary or secondary coming after a trauma. We really don't have any great criteria to diagnose this, and especially in those early stages where the patient won't let you get to an end feel. Very hard to diagnose in early stages. So we keep that in mind in our treatments. Therefore, don't have we don't have super great evidence to support what we do. Probably the best evidence we have is that manipulation under anesthesia that Boyles did with that translatory manipulation. And the picture of those procedures are below. And our patients may not be able to tolerate the aggressiveness or the very aggressive manipulation that Boyles did in those trials. But if we can get them in positions here like these and be able to do some mini high velocity, low amplitude thrust with just much less force, they may respond to that and may let you do that. We do have to be careful, especially depending on how much true inflammation we think that they have at that time, that we're not aggravating that. So joint mobilizations, we have some evidence behind. Johnson found that probably our posterior glides are a little bit more effective than our anterior glides. Vermeulen found that our high grades had the very slight nod over low grades, but like I said in many threads, this was not really matched to the patient's presentation, whether the patient is highly or low irritability. So that they may have better evidence. It may be more effective when appropriately matched to the patient presentation. And then Seelig found that adding mobilizations into our passive range of motion and stretching was more beneficial than not having that in there. And then some other lower level evidence that may be able to get, our gains in this population are very small. So if we can do anything to kind of help those along, then it additively can make a big effect. So some dry needling that Dr. Cluley found, and then some thoracic manipulation may be useful in this population. For our proximal humerus fracture, we did find that early mobilization seems to be key for how long for their positive prognosis, and definitely less than 3 weeks, assuming that the fracture is stable. And that brings to mind that these patients have gotten a very pathoanatomical diagnosis, and our convention says that we should just rest and let that heal. And so they may have a high degree of fear of movement or re-injury. Nerve injury is also very common here in those with displaced fractures, somewhere upwards around 80%. But even those with non-displaced fractures were shown on EMG to have some nerve injury. Clinically, it's hard to diagnose this, but they may improve with our neural mobilizations and using test, treat, retest as that sort of our diagnostic test. So for next week, we're talking about shoulder instability, rotator cuff, biceps tendon dysfunction, and the objective exam for your group project is now visible under week 7, and that'll be due, the final subjective objective will be due next Monday. Okay, I'll see you guys on the boards.